maternal and newborn child care setting until the age of 18 months, where the mother and the baby, if all positive, are linked to chronic care, or if the child is negative at 18 months, it is discharged from the clinic. So as I said, Uganda, a country with a generalized HIV epidemic, adopted lifelong ART in September 2012, 1 year after Malawi had initiated this, and we used a regional first approach to roll it to the entire country within 12 months. At the end of the rollout, we conducted a technical review with the purpose of learning lessons during the rollout, what performed well, what did not go well, and above all, to make recommendations for consolidation of lifelong ART program within our national health system. We undertook a review of documents, especially policy documents. We also undertook key informant interviews, and we also reviewed records from various health facilities in 34 districts out of the 112 districts in the country. We also held focus group discussions and client exit interviews. We have a report about 70 pages to this assessment. But some of the key findings, generally we found from most of the respondents that they thought this was a good policy because it addressed a clearly defined need, a clearly defined intervention, and a clearly defined outcome. And above all, the health workers specifically thought that this policy was not going to change soon compared to other policies that were changing frequently and confusing health workers. However, some of the sticky issues that came up with this new policy was the issue of poor infrastructure and human resource, especially in the lower health facilities, which were not able to implement this policy. We also had partial accreditation of the health facilities. That's some health facilities were accredited to offer general ART for pregnant and lactating women, but not general ART. So this caused confusion at the time of transitioning mothers who had progressed out of the PMTSD program. We also found that engagement of leadership, especially at subnational level, though critical, was not happening generally well in many districts. Regarding the PMTSD cascade, over the 12 months, we actually were able to bring 93% of sites to implement the new program. The ARV uptake increased from 49 to 72%, and this was mainly ARV provision within the maternal, newborn, and child health platform. Majority of the women received ARVs during antenatal care. However, some of them also received ARV during labor and delivery, and as well as during postnatal care. The retention rates were varying between 53 to 83% in the various health facilities. What was happened also that the number of eligible HIV positive pregnant women who needed ARV for themselves increased from 23% to 41%. However, we found from the review that these new guidelines did not have significant positive impact on the infant ARV uptake and linkage to EID. This slide shows the services, the integration models that were being used, especially in the provision of ARVs. As I emphasized earlier, that we emphasized provision of ARV within the maternal and newborn child setting. So, across all the health facilities, the clients were receiving ARVs within the NC clinic, labor ward, and the maternity ward, and where available the ART clinic and pharmacy. We however found that there was confusion in the transitioning of mothers who needed chronic care after accessing the PMTSD services. In some facilities, the mothers were linked to chronic care immediately after delivery, stretching from immediately after diagnosis to after delivery, or even to 18 months after diagnosis. So based on this, we actually had to review our guidelines, and now we emphasize keeping the mother-baby pair in the MCH clinic for at least 18 months before they are linked to care. EID turnaround time we found was significantly reduced. Overall, 72% of the health facilities reported EID turnaround time of 2 weeks or less, coming from an average of 60 days earlier on. But most important is that during the review also we found that most of the facilities reported no positive EID tests for mothers who had received option B+, actually showing you that probably lifelong treatment actually is effective in reduction of mother-to-child transmission. We also explored the perspective of the beneficiaries towards the services. We looked at the health facility physical accessibility, where we found that 14% of clients found difficulty accessing the facilities due to long distance, lack of money, or bad roads. 26% of the mothers explained that they spent more than 1 hour before being attended to, and attributed this to large client volumes and the few health workers within the health facilities. Overall, majority of the clients were satisfied with the privacy. They were satisfied with the counseling that was given prior to the initiation of ARVs, and up to 93% of the clients actually accepted to start the ARVs on the same day, and the majority of them again said they were treated well by the health workers. We also explored some of the social factors and their impact on option B+. We didn't find any significant impact by the cultural beliefs. However, when we looked at the gender norms, male involvement as usual showed a negative impact, especially in terms of disclosure and adherence to treatment, and some cases sharing of drugs. The other factors that we found were impacted were poverty and the migrant populations, especially of the fisher folks and the female sex workers who were moving from place to place in search of fund or income. One of the innovations, I think shared earlier by Christine from TASO, was the male action groups, which we thought were trying to encourage male involvement in this implementation. There were quite a number of challenges, but one of the major significant challenge we observed was that lifelong ART was weakening the implementation of the WHO four-pronged approach. It seems the health workers thought that lifelong ART was a magic bullet now, so they were not putting a lot of emphasis in primary prevention and use of family planning. So again, this is an area where we need to emphasize as we scale up lifelong treatment for pregnant women. So in conclusion, we demonstrated from our review that lifelong ART can be implemented on a national scale in resource-limited settings. The anecdotal information from IODI results provide hope for elimination of mother-to-child transmission. However, there is need to strengthen focus on prongs 1 and 2 and keep mother-baby pairs within the MCH clinic for up to 18 months to minimize lost follow-up. A centrally driven rollout can produce the required rapid results while building the subnational capacity for sustenance. And Christine previously shared with you some of the new policy guidelines that we have adopted as a country. And we have actually reviewed and realized that in Uganda now we have less than 300 people who have been left out of treatment if we go by the new ART eligible guidelines. So we think if we get more resources, we should be able to go to test and treat to cover all this. I thank you for listening to me. I want to acknowledge this organization. Thank you so much.